initiatives that we are pushing forward in our community to make sure everyone is aware of the mental health charge that we are all engaged in terms of making sure that we are prepared to help our youth and families through what a crisis it is we have going on right now. So I want to introduce two of our friends from Parkview and Bowen Center. Laura Murphy from Parkview and Siquilla LieBetrau, Dr. Siquilla LieBetrau from Bowen Center. I'm going to give them the mic so they can further introduce themselves and what they do.
Well, hi guys. I am Siquilla LieBetrau. I am a psychologist by trade, and I am the Vice President of Clinical Services at the Bowen Center. I've been with the Bowen Center for about 13 years, and I'm really, really passionate about caring for patients, and especially caring for patients that typically gets left behind by society, the folks that become prickly because life has done bad things to them and their circumstances have been awful. So that's my passion, and I'm just so excited to see you all here today because I know this is not just about what Parkview and Bowen is hoping to do, but we need all of you. The crisis is amazingly, ridiculously huge. And so we need every caring heart, every person that is willing to engage and help and support to manage this crisis. So thank you so much for taking the time to be here today and to share in that mission with us.
Thank you for saying that, Siquilla. And I'm Laura Murphy. I am the Director for Outpatient Services with the Parkview Behavioral Health Institute. By training, I'm a licensed mental health counselor, although I predominantly work in administration and helping with our program facilitation now. My area, where my heart is at, is really in serving the underserved, very similar to Dr. LieBetrau, but specifically in my practice, I was very focused on kids and families, particularly kids that were coming out of trauma backgrounds, which we know, right, impacts their development in so many ways and is so impactful. So again, I just want to express gratitude to all of you who not only signed up for this training very quickly, but came on a very rainy day. So thank you guys all for being here. Also, just want to ask you guys, just to get started so that we have an idea of who we're speaking to in the room, how many educators do we have in here who work in an educational system somewhere? Okay, great. Mental health providers, so you work in treatment. Okay, fantastic. People who would say that you're connected to the DCS system, the foster care system, right, in some way. Wonderful. Okay. Who am I missing? Who's in the room that I haven't asked about? Clergy. Okay, clergy related to churches, spiritual. Excellent. And thank you guys for coming. Yeah. Social services. CASA. Fantastic. Who else? Shout it out. Yeah. Music therapy. Thank you for coming. We love to have you. Okay. All right. So we've got a really wide variety of people who are in this room today, and that helps us to know who we're speaking to as we're hoping to share information that's very relevant and speaks to you. As we talk about what our learning objectives are for the day, we really have 4 things that we hope that you're going to walk away with. I think first and foremost, Siquilla touched on it, we are in a state of crisis when it comes to our youth. I think I'm probably telling you something that you already know, which is why you signed up to come to this training particularly. But hopefully what we're going to share with you today is some of the research and put some numbers and names to the things that we've all felt in our gut and our core around the crisis that we're seeing with youth mental health. Secondly, we want you to know what we're doing about it because we are doing something about it. And so we want to share those plans with you that are fairly early in formation, but I think I've said several times to people, you know, we're going to battle for our kids' mental health and we need an army. And so there is a call to action. We want you to all come with us and we want you to be on board of how can we go and fight for their mental health, fight for their life, fight for that stability. We want to make sure that you also leave here with just a sense of hope, right? That things can be better. We're not going to be stuck in this state of crisis long term, and that we are going to do some very intentional things with some intentional metrics that we'll be able to track as time goes on.
I hope I'm not misspeaking here, but are we joined live now by our participant
I don't
friends?
know. Are we live? We have a thumbs up from the good-looking guy on the left. Yes, we are live.
Yay!
All right,
Thank
well,
you,
excellent.
Noah. Okay, great. Welcome everyone live. Sorry, we had some difficulties getting connected, so we're happy to have you with us. Do they need any instructions to
No, it's
Join,
pretty
connect.
standard. They just look at their phone,
just look at your
which
phone?
we're really good at as a society.
Okay, thanks, Clinton.
All right, so let's go ahead and jump in. And I don't think we can talk about mental health in these most recent years without acknowledging the impact that COVID-19 had on our mental health. And I see a lot of people nodding, right, in the audience as we're talking about that right now. There's a resource page that Clinton may have already pushed out or will be pushing out to everyone. In that resource page is a link to this full study that was pushed out by the School of Public Health at IUPUI, which really touches on just what was that impact of COVID-19 on behavioral health when we look at the state of Indiana. It's an amazing article. I encourage you to go read it. It had a lot of aha moments for me and just solidified a lot of things that I had really felt in my gut as well. But I think just a few of the highlights that we want to just touch on here and bring to attention. We know COVID-19 had an impact on mental health, but the question is how much, right? How much did that impact mental health? From March to June of 2020, during that period of time, 14% of parents reported that their kids' mental health worsened. Is that kind of ringing true for people that during that heightened time we saw that, right? Kaiser Family Foundation did a little bit of research and went even further to start identifying the drivers behind that, right? So mental health declined, but why did mental health decline and why did it decline so quickly, right? We had school closures, we had social distancing, and I think these things have to be coupled with what we know normal development looks like for kids and adolescents, right? What's the role of friendships at this age? What's the role of that social community and that peer group? And so many of those kids were just completely removed from what we would consider to be normal development and pushed really predominantly into their family home systems, which may or may not have been healthy at the time. And also what we know about normal development is that during those teen years, that stress between parent and child, it's normal, right? We see it across the board. That's healthy, normal development, but now we packed these families into a bubble, right? And now we took stress and we kind of turned the temperature up on it just a little bit. We also know that those families that are in our lower socioeconomic categories were disproportionately impacted. And so think about these families who were greater impacted by parental job loss, who had a greater impact because they didn't have access to free and reduced lunch at school. Families whose work schedules may be very rigid, right? Childcare became an issue that we may or may not been able to cover. And I think collectively, as we look at the COVID-19 pandemic, it really was a trauma that we all walked through. And so as we talk about specific traumas, right, and we do training on trauma all the time and trauma-informed care, and we talk about abuse and neglect, we can't also neglect the fact that we have this now collective trauma that we all went through. And I'm sure, Siquilla, you've probably seen similar things at Bowen Center as well.
Absolutely. Oh my goodness. I was just having conversations this week with folks as we're looking at expanding virtual services. Again, I know when COVID occurred, we all just kind of quickly switched to virtual services because we knew the need was out there and the need was ever greater. But as we're now having conversations about sort of expanding back into virtual services, we're hearing from our providers that they're still suffering with trauma symptoms related to that original switch. And we're the helpers. We're there to help everyone, and that's where our heart is, and that's where our work is. And at the same time, still today, there's ongoing impact where our providers are having flashbacks and nightmares and memories about what it was like to switch so quickly and to want to help, but at the same time feeling like they didn't have the tools to serve patients necessarily virtually. At the time, we did whatever we could, right? We did video services, we did phone services, and it just felt really clunky. We were serving littles, itty bitties that, how do you do play therapy across a screen? for maybe 45 minutes or whatever the original session was set for. So we're still seeing that with providers. And I think in this whole conversation, I want to make sure that we recognize our providers and their needs. You are all in the room, providers of different types, and you care about children and youth. And so I want to make sure that there is a focus today, too, on you and your needs and how we can care for you. But when we look at patients and what we've been seeing at Bowen, too, I think there's this desire to just put COVID behind us and just go, okay, it was awful, we're going to pretend it never happened, and we just want to move forward because we're just so exhausted from it. But we still see 6- and 7-year-olds walking in through our clinic doors every week. And that just breaks my heart. We've always, as a care community, seen suicide, helped folks with suicidal ideation, but it was, we saw teenagers, maybe rarely kiddos, but now it's a daily thing. It's a daily thing that we're seeing those kiddos coming in, and it's just heartbreaking.
And I want to just ask you, and you can just kind of show hands here, have people felt the stress on your profession more profoundly in these years since the COVID-19 pandemic? Just yes, an agreement, like just a collective, like, right, we're going to acknowledge each other that this has been really hard work. I also want to say COVID-19 was not the only thing that drove youth mental health. I talk about it and I say, but it was like pouring gasoline on a fire, right? We knew that mental health for our youth was poor prior to the pandemic hitting, and then we just like added the accelerant, right? And we added an accelerant without all of us being well equipped, right? We're flying the plane while we're building it, which feels really hard to do and takes its toll. So I also just want to pause and just say thank you to all of you who are still in the field, who haven't left the field, who have stayed in the trenches, who have done the hard work, who have, right, done the hard right turns and turned on a dime, because that's how we serve our youth, and that's, right, it doesn't go away just because we decide to walk away from it. It's still there.
Ladies, I want to rudely interrupt because you're jumping ahead of me, Laura, with good questions that I want to ask them too. But I do want to let you know what our audience looks like now, since you asked earlier. We have a very interesting group in regards to the group makeup. Our largest group would be people in social work, and then secondly, the next group would be the mental health field, educators at 10%, other at 6.9%, but you can see those other areas that are represented. 189 guests interacting today, and highly female, of course, which we kind of know. But then I also want to point out the age, and this is just for my own little sociologist in me, that we have a group of people. We need, of course, this industry to continue to grow among young people graduating from high school too. So just really thankful for you participating. And Laura, if you have any questions you want me to ask the audience, throw them my way and I'll pop them out there.
Absolutely. Thank you, Clinton. All right. So let's go ahead and start talking about what we've seen in addition to the COVID-19 pandemic. So that is one aspect, right? It's an important aspect. It was a contributing factor. We can't ignore it. It had huge impact. It will continue to have huge impact. But also, what else do we know about youth mental health? And a lot of the studies that we're starting to get back are done, right, on the worldwide level, right? What's been happening around the globe, right? What's been happening in the United States? What's been happening in the state of Indiana? But it's also important to talk about what's happening in our backyard. And I'm going to share some information with you that what's happening in our backyard really isn't any different than what's happening across the state, although in some areas we're actually performing worse compared to some of our peers. And I think those are some things that we need to pay attention to. So Parkview, as a non-for-profit hospital system, does what's called a triennial needs assessment. So every 3 years, there's a survey that goes out to the community that we serve to really identify what are the top needs of the community, right, of the people who live in the community. This is not an assessment of Parkview. It's not an assessment of Park Center. It's a need assessment truly of the people who live in the community, with the intention that it will help identify needs, and then as a health system, we can build intentional programming to hopefully, right, close gaps and meet those needs. As we talk about the needs that came up in the community needs assessment, these are also the needs that have been identified that not only are they in high demand, but they are also the needs that as a community, we are poorly equipped to respond to right now. We don't have what we need to, close these gaps. And so we have to be intentional about it, because just wishful thinking is not gonna get us to where we wanna be. So the provider survey that went out really looked at 3 counties, Allen, Adams, and Wells County, and that's because those are the counties where Park Center is the community mental health center. However, as I share this data, I do think we are here in Allen County. It's gonna be very reflective for most of you and the service areas that you have. But also, as we look at our surrounding counties and we look at those more rural communities, Wells County, which is Bluffton, Adams County, which is Decatur, the data to me would look similar if we were also polling Huntington, Whitley, Steuben, DeKalb, Noble, because what the data says to me is we're not that different than the rest of the state. And I know, Siquilla, you've also had some contact in those rural communities. Is that your feeling as well, that the needs aren't different just because it's rural?
Absolutely, and that's where my heart is, roaring, that's not a word, serving those rural communities. That's where Bowen's footprint is. Of course, we're here in Allen County and it's important, but part of my message to you all today too is we see you if you're in a rural community with few to no resources. We want to make sure today and beyond with future efforts that we support you as well, even if you're in a county where you're much further away from Allen. We're talking about Marshall, Wabash, Huntington, Elkhart, St. Joe County. I mean, everywhere. We really want to make sure that we provide services for you, and I would absolutely echo that. I've been seeing the same thing in our footprint that Laura's talking about. And if I could just say for a second too, you seeing the two of us here together next to each other on this stage today is for a reason. I'm here as part of representation of Bowen. Laura obviously is here to represent Parkview. And I think traditionally people have thought about Bowen and Parkview maybe as 2 large mental health systems that are arch enemies or something. But we're really here to say, we see the need of the children, and that need is much greater than what any one of our systems can care for alone. And so we're here together to say, we want to work together. We want to pool resources. We want to support our communities in whatever way we can. It's not competition. The communities and the children specifically need us.
I just want to comment here too. That's something that Great Kids is heavily invested in this past few years, is bringing entities together that may be considered competing for the same dollars, the same clients, et cetera, in the interest of the need of the community. It really harkens back to the core of Great Kids, and that is to set these kids up with assets. One of these assets is that, we would build a sense of integrity and empathy and, honesty, and those types of things are best coming from adults when they're modeled. And so when we have organizations that we pull together for a training such as this, and they're collaborative in the sense that they recognize that the needs trump the individual entity or the efforts to get their name out there, that's something Great Kids fully gets behind. So I'm really pleased to keep partnering and offering these types of opportunities for you.
And I think, ladies, I want to show you where our friends are from. Allen County well represented, but you can see down that breakdown that we've got 19% from other counties other than we have listed there in the immediate area, and then 13% from DeKalb County. So a good representation of Northeast Indiana here today, which is awesome.
Yeah, and so as we talk about that community needs assessment, and we start to break this data down into what did we actually find? There's a lot of numbers and statistics in the community needs assessment. You have the link to the full file if you so desire to go out and read it. But I just pulled the high level trends here that I think are important for us to have our eyes on. The two top trends that came out loud and clear across the community needs assessment is that mood disorders are worsening across all of the counties that we serve, and that child and abuse and neglect, while improving, is still twice the rate of the national average. So let's break that down into what that actually means, right? So I think most people are familiar with mood disorders, but just to make sure we're on the same page, we're talking about depression, we're talking about bipolar disorder, often people who have suicidal ideation, people who might retreat into themselves or sometimes, right, become aggressive and outward. The antidepressants, the mood stabilizers, right? We're seeing greater need and demand for all of those things because the mood is fluctuating significantly more. Child and abuse and neglect, we're getting better. So that's the highlight, right? That's the silver lining and that's the takeaway. Our numbers have improved across all counties that we serve. However, when we compare to the national average, it is staggering. Translate that into, what does that mean? It means if you're a treatment provider, it's twice as likely that the person on your caseload has a trauma history. It's twice as likely that the parent parenting them has a trauma history. It's twice as likely that your colleague has a trauma history. It's twice as likely as the person sitting at your table has a trauma history, right? Taking that into educators, twice as likely that the student in your classroom has a trauma history, the person in your congregation at your church has this trauma history. And so it's no longer enough just to be trauma informed. We have to be trauma responsive. We have to change what we do in light of having this information. And Great Kids does amazing trainings on trauma informed care and practices that can be implemented here when we talk about those pieces. And we didn't cause the trauma, right? But we do have a responsibility in how we respond to it. And it's okay to see some of this data that we share and be righteously angry about it. I think that's actually a good thing when we talk about our kids, right? We want to be righteously angry and upset to fire us up to go do something about it. We look at each county's breakdown as to how these counties are really playing out across here. And so when we look at Allen County specifically, and we compare ourselves nationwide, we're actually in the bottom quartile in the United States regarding alcohol abuse and mental health. So what that means is 75% of the country is doing better than us, right? We are in that bottom 25% that's happening. We know that alcohol use in Allen County is worsening. Because that's what we're being told, right, by the community. Alcohol use is worsening. We know that mental health is worsening. In Adams County, again, we're trending in that bottom quartile when it comes to mental health, but rather than alcohol use, it's actually tobacco use. That's what's coming up more predominantly in that county. Again, mental health is worsening. And then we get over to Wells County, and again, we're in that bottom quartile when it comes to tobacco use. And again, Wells County mental health is worsening. And again, while I don't have a study and I don't have a survey or statistics, my guess is that this looks the same in our surrounding communities and our surrounding counties, that mental health is significantly worsening. So before I go to this next slide here, Clinton, I'm curious if you can just kind of push out a question to the crowd here about what they perceive those top mental health needs to be. And I'm going to hit one more slide before we come back to just what you've seen. So I want you guys to just take a moment. Think about those needs that you see. When it comes to mental health, what specifically are we talking about with our youth? So while you're answering that question, I am going to share one more piece of data, though. So part of the community needs assessment that we do goes out to providers, and it's really asking for that provider perception, the people who are serving in the schools and the treatment settings, right, in doctors' offices and the legal system and the DCS system, to say, what's your perception here of the top service needs? Not the top mental health needs, right? Not the top substance use needs, but the top service needs that exist in the county. And I want you to look at all of the top needs that really came up on here. So we have a significant list of things that are on here. And I want you to also notice the two, right, that take the cake at the top, right? Mental health and substance use. There are some significant things on this list. I think about myself. I have 2 young children at home. I know that childcare is also at a crisis in our community. It's not available. It's not affordable. There's a lack of infant care, but also childcare came in fourth, right? It's a need, it's a significant need, but it's not as great of a need as mental health and substance use is perceived to be. I think also just noting gun safety, which is on here. there's so much, right, attention and focus on gun safety. We have mass shootings that are happening across the country. We have homicides happening in our backyard. We have youth that are both victims and offenders of homicides, right, in our community. But what we attribute that to, and I say we collectively in terms of, right, the citizens of our community, we attribute those things more so to mental health and substance use. And how do we tackle those pieces? How do we address that? So Clinton, I'm curious if we have any data back.
We sure do there, Laura. Look at these answers. And these are just some of them. There's hundreds coming in, because again, you're allowed to submit more than one. But this is just the trends that I'm starting to see already with that question that you wanted me to push out.
Yeah, and thank you guys for chiming in here. Depression, mood disorders, coping skills, self-esteem, anxiety, right? These are all the things, right, that make it so challenging for us to respond to, because you start to look at this list and then you say, well, how do you prioritize, right? These are all priorities. These are all intense needs, right? It feels like I'm drinking from a fire hydrant a little bit as well. So I'm going to share with you the data that came back from our community needs assessment as well when we started to look at, well, what are those top mental health needs? So now we're dialing a little bit deeper. You've said mental health and substance use are the top needs. What is that we're actually looking at? And I think the community tends to agree with you. Mood disorders is up there at the top, substance use and abuse, child abuse, the anxiety disorders, right, suicide. And if we were to draw a line as to kind of what really are those top focuses here, right under suicide is kind of where that defining line comes in, to say those 6 at the top are predominantly what is driving our crisis in our community. And a lot of these things go back to areas that Clinton, I know the Get School Tour touches on, with just escapism, right? Our kids don't have these healthy coping skills that you guys said is a need, right? And if you don't have the skills to cope with the stress that's coming to you in life, what do? You escape. And how do you escape, right? You escape in lots of different ways, through your cell phone, through social media, right? Through, right, sometimes alcohol or drugs. Sex for our kids, right? Like, they move to these unhealthy ways of coping to try to regulate because they don't have healthy ways of coping to regulate their own bodies.
Laura, I sort of interrupt, but I'm getting some comments about the assessment that they would. Can you give us a 30-second commercial again as to what this was and how this was done?
Yeah, absolutely. So the Parkview Health System, we're a non-for-profit hospital system, and so every 3 years, we do what's called a triennial needs assessment of the community. This is an assessment of the community that we serve in terms of what's considered our catchment area. So for Park Center, our area that we serve as the Community Mental Health Center is Allen, Adams, and Wells County. These surveys go out, it's actually done by our research department through Miro Center, to survey the community and identify what is the community identifying as the top needs that the community also perceives that as a whole, right, collectively, not Parkview, but as a whole, we're not equipped to deal with it, and we need a plan, right? It helps to steer us to say, well, where does planning really need to focus for these next several years, intentionally dialing in? So prior to this most recent community needs assessment, which was actually completed in 2022, the prior community needs assessment, not surprisingly, had identified the opiate crisis as a significant issue, and that drove a lot of the work that happened in our community around how do we respond to this and treat this.
Yeah, there's a lot of accurate, I see this in my work, and then that top comment, sad that Indiana is twice the amount of the national average. Any thoughts as to why that is, Laura, Siquilla?
Oh gosh, so many. I think we're predominantly still a rural community. I think that in many ways we are late adopters to some of the evidence-based practices that are coming out. But I think also because we are a rural community, we also know that it's harder to necessarily get our expertise and our treatment providers who have the credentials and the training that they need into some more of these communities who they don't have that access. I think Siquilla touched on just the heart that you have for serving those rural communities, and I know there's a lot of research that are being done into what's called hub and spoke models of how can you create these spokes that come out of the more urban areas like a Fort Wayne to reach some of these more rural communities, because people are still struggling with mental health. They just might be doing it alone rather than with someone. Do you want to add anything as to what you see driving this?
Yeah, I think it's really just tricky to get providers in rural communities, right? People don't want to drive a really long distance. Maybe they don't want to live in a rural community themselves, even though I think it's an amazing place to live. But I think looking at that, there's a provider shortage. I think, honestly, the helping professions are not paid well enough. That is something we hear over and over. If you compare salaries in helping professions with with corporate types of salaries, you know, it's like a whole different world. So we understand, we recognize that. I think burnout has been a really big thing for people as well. There's been lots of statistics shared about burnout in the health industry in general, but in the mental health field, we see that. We see that all the time where people get so burned out, they don't want to just leave the organization. They just want to leave the field altogether. It's just too much. And I know we talked earlier about the trauma around COVID and all of that, but our providers have been struggling with their own trauma. So you are really multiplying that impact where their own families are suffering, they've lost loved ones, their own kids are struggling, and then they go to work and they serve other people. So I think that trauma as well. You know, to become a licensed provider in the field takes a lot of time, energy, and money. And so the providers don't get paid well. It costs a lot of money to get the education. So, and I think those are some things we'll talk about a little bit later too, as we talk about the Riley study. There's all of those pieces. I think what we see too is that although we've made a lot of strides to overcome stigma about mental health treatment, it's still a thing. And so there are other things we can do, and we'll talk about that, things like integrative care that really makes a difference in reaching those populations that traditionally would not have sought out mental health care specifically. And then we see things as well in rural communities. For instance, farmers are one of the populations that really are getting hit with suicide as well. I'm sure, Clinton, you can share some additional statistics, but I think if we try to come up with a simple answer to any of these questions, we're going to miss the mark because there's so many contributing factors. So it really needs to be a multi-pronged solution.
I just want to say, because you guys have hit on this, these individuals, these incredible superheroes in our society here, this is their current mental health concern, right? And so back to the stewardess on the airplane, you can't help the person next to you unless you put your own oxygen mask on first. And I know we've done events about that, but I just want to say thank you for referencing that, because these folks are on the front lines. This is their mental health situation, and it's difficult to do the work when you're struggling as well.
And I just want to add on to something that Siquilla said as well regarding just access to providers, which we know there's a shortage of providers and access is difficult. It gets even more difficult as we get into the rural communities. And so in the link that you have to the full Park Center needs assessment, there is some data that shares just what is the breakdown in ratio in terms of mental health providers to the community that we serve. And there's some stark comparisons here. So in Allen County, I don't know the exact number, but it's about, for every one resident of Allen County, there's about for every one mental health provider in Allen County, that would serve about 500 residents of Allen County. Seems like a large number to people. I saw people's eyes kind of get wide. So let me tell you what it is in Wells and Adams County. It's about 1 to 2,500. So how are we supposed to meet the needs of the community that for every 2,500 residents, we have one mental health provider when we know where the statistics are with people who are struggling with depression and anxiety and suicidal ideation, which also means they need to be seen more frequently and more intense services, but also our providers can't work themselves into the ground because then you burn out of the field, right? And you leave, and now our numbers only go up because we have fewer people rather than more, right? So it's a very complex problem, as Siquilla said, and you know, you don't do it justice by trying to pin it down to one thing, but I do think having the dialogue that we're having today, what are all of these contributing factors that we have?
Laura, if I could just add too, I think another big piece too, if you're talking about our rural providers, is that it's so hard to get training. It's hard to get training where you're at. So oftentimes, if you want to get more training to be able to help in a more specific way, you have to take time offline. That means patients that are not getting seen and getting served. So our hearts go out for those patients. So it's this tug. I want to get more resources. I want to learn new techniques. But while I'm doing that, somebody is not getting served. Many somebodies are not getting served. And it's tricky. You know, all of these big, beautiful evidence-based treatments out there often takes many hours to complete. It's expensive. You have to travel to a location where you can get it. It's not offered very often. So we're very aware that there's a huge need, and I think part of our collaboration and what we will both talk about more today include efforts to bring some of those resources to you.
I do want to represent the crowd a little bit here. I asked them, you know, why they think Indiana's so high. We got some very candid answers, which we love at Remedy Live. We talk about those things we just don't talk about. I'm gonna leave these up here for a while, but I do want to just take a second to do a commercial about our May event. And Amanda, can you kind of give us a reference that this is kind of a starting point for a bigger conversation in May?
Right, so on Tuesday, May 21st, you are all going to want to mark your calendars. We are now driving forward and putting efforts towards a youth mental health summit. It will be held here at PFW, both in this room, but the whole room, as well as a few classrooms. And at this point, we're shooting for probably a 9 to 4, so it will be a full day. We will feed you, because we always do. That's what Great Kids does. Also, we obviously will provide CEUs, just like we always do. But yeah, we're driving forward this effort to get more resources and more education out there from a mental health perspective. So go ahead, please, and mark that in your calendar, and you'll see more to come as we make more decisions on training topics and speakers.
And I say now is a great time, so you guys have the ability to send in questions or interact with us. If there are particular topics that you want to see, let us know. We do, have some things in the works, and we're getting things scheduled and speakers nailed down. But we are still open to what you guys need, right? Like, this is to serve you, to serve those of you who are working with youth and families. So let us know if you guys can think of any specific topics. As of right now, we have some speakers that are going to be speaking on like vaping, substance abuse issues, minority mental health. So we have, like I said, a few topics that we know we want to hit on, but if there's something that you think we might be missing that you think really needs to be a part of this summit, let us know and we'll do our best to bring that.
Just because we're nearing almost the halfway point, I do want to make sure you also know I did push the resource page to your phone. So this is a very full page of links and PDFs, and one of them is, of course, for the May event. But what I want to do now, to your point, Jessica, is push out topics that you might be interested in seeing at the May event. So that's also on your device right now. If you happen to have left the polling by clicking those resource pages, of course, it'll open a new tab on your device. Just get back over to the tab that allows us to do some more polling.
One more thing I wanted to mention, it came to me while Jessica was talking about topics. If there's a particular speaker, too, that you've always wanted to see, always shoot that to me. I think it's probably not a secret in this room that I go after and talk to a lot of speakers all year round, not just for the May event, but for this little thing we call the Annual Conference on Youth in the fall, which is what Great Kids is mostly known for. And just to touch back a little bit on the subject of burnout that has come up today, I just want you all to know that we see you. I read the evaluations, I see who's registering for what, and I see that you need sessions on burnout. So that's also something that we have, as a committee, talked about making sure we incorporate into this session. So as much as we want to communicate to anyone who's struggling with mental health, that goes for providers as well.
So there's one more slide I'm going to share here with data from our community needs assessment. And this is just showing you a graphic of where does the state of Indiana fall in terms of the rest of the country that we're looking at here. So the lighter gray colors that you're seeing are the states that are higher ranked. That's a good thing when you look at this graphic. That means in comparison to the norm, how are these states trending when we're looking at the prevalence of youth mental health specifically? But also draw your attention to where the state of Indiana falls. We are the absolute lowest ranking that we can have. We actually couldn't get lower on the color scale, right, if we tried. But then when we look at where do we rank and where did we rank in prior years where this was looked at nationally as well. So in 2022 is the last time that rankings came out. Indiana was ranked 26 out of the 51 areas. They do include the District of Columbia here. So 51 areas were ranked 26 in youth mental health. That is a decline over where we were ranked 2 years ago, where we came in 19th in 2020. So we dropped, right, seven slots here in a span that's pretty short period of time. Adult mental health also declined, and this is pretty staggering. We are now 43rd when it comes to adult mental health. What's the one thing all kids have in common? Parents, adults, right, teachers. And so what this tells me is not only are our youth struggling and we have a crisis around youth mental health, their family systems are struggling, their parents are struggling, our providers are struggling. I appreciate the transparency in regards to Clinton's question. We're struggling in this room, right, with depression and anxiety and our own things that are going on. And we can't pretend that doesn't have an impact on the way that we deliver care or how available we are to show up or how much capacity we have in any given day. And the hard part is we know the demands of the job are never going to slow down. Someone asked me a couple months ago, they said, oh, well, what's the slow time of year for you with Parkview? To which I just laughed, and I was like, there is no slow time, right? Like, it feels like the gas pedal's down all the time. It just changes, right? Who's pushing that gas pedal for us? But there used to be slow times, right? And I think we all used to feel those like, oh, at this time it's a little bit of a lull, right? And then we kind of pick up at this other time. That doesn't exist anymore, and we're also not going backwards. We can only look forward. And so I think there's a piece for all of us as providers of grieving what used to be, right? Grief and loss is so important. Grieving what was lost, grieving the way that things used to be, the way we used to be able to practice. And we have to do that so that we can step forward and embrace what the new medical models are telling us, what the new research-based techniques are telling us, that we can turn and change. And it's hard, right? Like, it's super hard. The way that evidence-based medicine is telling us to practice today is not the way that I was trained in grad school. It's not. It's not the opportunities I had in my internship. It's not what I had during my clinical supervision as I was getting licensed. And so now this is real time, on the fly. We've got to change with large caseloads and high demand and high acuity. And I don't have the ability, right, in that space to practice these skills. It also means we can get better for our new graduates, right? We can help them practice the skills and learn them and hopefully put them into a workforce, right, with a leg up. And that they're a bit more equipped. But for those of us who have been in the field for a while, it's a hard turn for us to be able to do. And overall, you see up here, when they just look at overall mental health, we're ranked 42 out of 51. It's unacceptable, right? And I hope that drives just a righteous anger for everyone in here. I know I've said that a couple of times. We should be upset about that. We should want to do something about that. And not just do something. I think what I love about youth is as I talk to people and we pull people together to plan, and even planning for this event, the one common theme that continues to come up is people have said, I will give you my time, my energy, my talent, right? But I do not want to have a meeting just to have a meeting. I do not want to have a conference just to have a conference. We need to have an impact. We need to have metrics. We need to have outcomes. We need to make a difference. And I love that. I'm not going to lie. It's intimidating and a little bit scary to also think about how do we, right, leverage and move all of these things forward. But I love that because people want to do things that meaningfully make a difference. So I'm going to kick this over to Siquilla, who's going to continue talking about some of the things that are happening at a larger scale.
Thank you. So really we wanted to highlight some of the efforts that are going on right now so that you can, again, that piece of hope that Laura talked about, we want you to know about the bigger picture efforts that are happening and then maybe how you can fit within those efforts or at least know what's coming and start sharing amongst each other and get excited about those big things. So just really quickly, we'll talk a little bit about the Riley Children's Foundation. and the research they did and what they found. And then we're also going to talk about specific crisis response pieces, namely 988 and CCBHC. There's lots of letter soup in our world, so we will go through all of that. So first off, maybe a show of hands. Who here have heard of the Riley Children Foundation study, or have maybe attended one of their events? Okay, so a few people. That is one of the other resources that Clinton either already has or will be pushing out to you guys. There is, Riley published their study. So basically what they did is, first of all, they recognized things are going on. The children, the youth are suffering within our state. And so that was a call to action for them. They wanted to look at exactly what's happening and what should we do as a result of what is happening. And so there's a few statistics. I'm not gonna read all of these things off. Again, you guys will have access to the whole study, the Riley study. But a couple of things. Indiana's youth suicide rate has been higher than the national average since 1999. So this is not new. We have been in that hole for a really long time. It's just getting worse. Also, 22% of high school age girls and 12% of high school age boys seriously consider attempting suicide in the last year. That is so sad. That breaks my heart, because that means they don't have the social support they need. It means they don't have the coping skills they need. And something else that we learned a lot through COVID, a lot of research has been done on resiliency. They don't have resiliency built into their systems. And I think part of that was because they were removed from all these resources during key phases and stages of development. So things that would have naturally been acquired just didn't happen for them. Then suicide is the second leading cause of death for Hoosier adolescents. Again, that's heartbreaking. I know Clinton sees that all the time. That comes to his attention. I don't know if you want to say anything.
I made sure to bring some data with me, and I'm going to see if I can push it up on the screen here for us. First of all, for some of you that know remedylive, you know that we have been very committed, especially since the pandemic, to doing all that we can to collect this data. So 160,000 students have seen the Get School Tour since the pandemic. And you can see all the demographic data. And I'm going to actually push this to your device so that you can actually download it yourself. That way you can have it on your phone. But to your point, Siquilla, your point about suicide, we see the exact same data. We asked 11,500 students, have they had serious thoughts of suicide in the last 30 days? And you can see the data there, 17% saying yes. And so when we're in the school, and again, I got a couple of rock stars. Graham and Anthony, stand up over here. This is our Get School Tour director, Graham Brown, and Anthony Pons is our speaker. They are in 4 and 5 schools a week, trying to do all that we can to lower the stigma around having these conversations, because the students are in that struggle. And we've been so thankful that Bowen Center's gone along with us to every one of those schools. So thank you. Because we have to make sure we provide immediate talk room support to these kids that are struggling with these secret struggles. So I have a lot of other data. I could bore the socks out of you, but I'm going to push that to their devices now.
Thank you. And I think what is terrifying to me too is we know the research shows if there's been one death by suicide in a community or in a family, there's greater likelihood that another will follow, and another, and another. And this is really just not something we can allow to happen. Many of our organizations are part of what's called Zero Suicide Initiative, and really the thought behind it is how many suicides are acceptable? And of course the answer must be 0. Maybe that's not a realistic goal, but I'm okay with having that unrealistic goal of saying we must attempt to have 0 deaths by suicide.
And that 17% that Clinton shared, I want you guys to think about what that means for you, whether you are a treatment provider and you have a caseload, whether you're an educator and you have a classroom, you're a school administrator, you're right with a church and you have a congregation. Put a number to that 17%. What does that actually look like? And is that surprising to you that that many people are struggling at any given time with thoughts of wanting to take their own life? And we know that kids not only think about it, they do it, right? We know that we have adolescent and youth suicides in our community, and that creates also this ripple effect that also is very complex. It leads to traumatic grief. It's hard for kids to process, right? How many of us of adults would say, I have an adequate coping skill, right, and support system that I can in a healthy way process the death of an adolescent? I don't, right? I don't. That rocks me to my core when I see that. And so if we're rocked to our core, where are our kids at? Not just with suicide, but the kids then who are grieving the loss of these homicides, kids that they went to school with, kids that they saw, right? Kids that they were friends with. And both suicide and homicide come with this level of shame connected to it, right? And so we as a community don't know how to respond to them. And we have this complex and this very traumatic grief. I know in the list of resources that Clinton pushed out to you, Aaron's House is included in there as well. In talking with Aaron's House, and we have been talking about mental health and just what are they seeing, the number of complex traumatic grief cases that are coming through, right? Staggering, these kids who are struggling with depression and anxiety, and for the most part are still making it to school and working their part-time job and doing the college application, right? And doing, right, the things that we tell them that they need to be doing, and behind the scenes, right, they're struggling with anxiety and depression, and they're trying to make sense of the fact that someone died from an overdose, or, right, somebody took their own life, or this person was shot, and there's this fear, and, right, there's now these suicidal, right, thoughts that they have. And how equipped are we as providers and professionals to even know how do we help them through that, right? How do we help them to start to cope with some of those? And Aaron's House is an amazing resource, so I just want to bring your attention there as well, that we have this great resource in our backyard to help with that as well.
And that resource is on your device. 1,928 real people, students. I have 4 teenagers. I know you guys have kids as well. So that's something I want to point out. I also want to point out the difference between the male and the female student. The female's higher at 1,205 there. I also want to mention, just to represent it, that we're also looking at data around overdoses, not just measuring them as suicides, but kids losing their battle with their mental health because of the increased use of vaping. The weed that is now on the market is a different kind of psychosis-focused weed, sadly. And then the fellas, what they're recognizing is that a lot of this escapes that these young people are doing to get away from this pain point in their life is slowly moving them towards experimenting with these substances. As we know, one pill can kill. We talk a lot about fentanyl in our community. And so it's not just suicide, it's also losing kids to just risky behavior as well.
Absolutely.
Yeah.
I'm going to give you the microphone so that everybody can hear your question.
We were just talking about specifically teenagers, and I know you said 1999, it seems to, keep increasing as far as suicide. And I Googled to see when Facebook came on, and it came on in 2004. So I'm going to assume MySpace was prior to that, correct?
Did you just say MySpace?
Yes. Well, in my days, we just had pen and paper. So.
Okay.
And we actually went outside to play. That's where we met all our friends.
Sure.
But so I just started thinking, all the bullying and you see it on a daily basis. And I, as a CASA volunteer, see it with a lot of my kids that, I work with. And, we still allow phones in the schools. You talk about, we were just saying there was someone that took a picture of a girl in the locker room or whatever, posted it on Facebook. And, how she's struggling with all that. We see it, we all hear it on a daily basis, but how do you address all that? how do the schools address that? How do the parents address that? I see little kids as 4 and 5 having tablets, and it's scary.
Well, here's the good news about it. So we've asked 30,000 students this question. The average is 9 hours a day of non-academic screen time. So this is alarming, right? It's 5 hours for you folks, because we know your average age is 43 in this room. But for these kids, it's 9 hours. Here's the crazy thing, though, ma'am. It's 50-50 as to whether these students want that in their life. There's an addiction issue. And so a trusted adult, and this is a great kids, pillar, trusted adults come in their life, and replacing that smartphone as the #1 line agent in their life with truth and support is the #1 key. I'd also mention here, just because I love that you brought that up, it's an older book now, but iGen really did a great job of helping us see the shelf of the, Remedy created the same week as the iPhone came out. I was the geek in line to buy 2 of them in Grand Rapids, Michigan. You can see a direct correlation between the smartphone and the spike of anxiety and the plummet of self-esteem and self-value. And so you're right, absolutely right, there's a correlation. But again, back to that trusted adult mix. That's why I so love that you're here. 75% of these folks work with families. We need you to continue. I'm also asking you a lot of personal questions about your own mental health. And as I want to say again, we need you. So self-care, 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 and come to more of these events to make sure that you know you're part of a wonderful family of care.
And that does remind me, that is something that we've actually talked to one of our speakers that will be at this youth summit about. We obviously are hearing that constantly, Amanda and I at Great Kids, about, teach us about kids and cell phones and social media and how do we stop them from. And it was interesting, the conversation that we had with this gal a few weeks ago, is she said, yes, there absolutely needs to be boundaries and limitations, right? 9 hours or whatever you said it was a day, just in extracurricular things, that's probably kind of excessive. But to say that we're just going to take the phones away and not allow them access to the social media or to phones anymore, it's not realistic. So really, I think one of the things that we as a community, and I know as a parent, have skipped over is how do we teach responsible use of, right? So rather than thinking about how do we confiscate all of phones within school, is that realistic when a lot of kids need to use that as their form of communication with mom and dad, or for transportation? Rather, we need to get down to the deeper issue of why is the bullying going on? Why are people taking pictures in, right? So we need to start having those deeper conversations as to if you're going to have a cell phone, or if you're going to have access to social media, how do we use it responsibly and respectfully? So
The analogy she used was, you don't learn to swim on your living room floor.
Yes.
And I thought that was very enlightening. I think often as a parent or anyone who cares about youth, I think maybe your first instinct, understandable, is to limit exposure. And I'm not saying that isn't appropriate. Certainly 9 hours a day is nutso, and that's a lot. But anyway, I just want to comment that yes, we do want to watch the amount, but we also when we were talking to the speaker, she mentioned, hey, they are going to do it with or without you. And if you limit, they're just going to find a way around that to get to what they want.
And again, back to the root system. There's always a root system, right? It's the smoke. We always talk about the smoke, the escapism, the screen time. But really, the root system is the identity and the relationship. So this is an important question from our data. This is 31,000 students. Do you have a trusted adult at school you could talk to about your secret struggle? And if you would talk to them today, 22% say I do, but I won't talk to them. And then 27% say no. The reason why I'm showing this is that, again, we do need to be more aggressive to ask, how are you really? Here's a free gift. I love you too much not to ask, how are you really? And then this is fascinating, just so you know that they're interested. This is the data, again, 20,000 students. 45% of them have had a conversation with another student about depression, anxiety, or another mental health issue in the last 30 days. So the students are talking to their peers. So 13-year-olds are giving 13-year-olds advice. We need to jump in the mix because they want to talk about it. But here's again, I have 4 teenagers, so I'm an expert, right? Listening's the key, not necessarily talking. Listening's the key. It creates the bridge of trust, and it's a beautiful thing to watch when a student feels like they're being heard. So, again, I'll be quiet now, but this is really relevant to what we're doing with the Get School Tour.
I just want to also add a message of hope as we talk about this and we talk about social media, and we all acknowledge and we say 9 hours is crazy to think that kids are on the phone, yet we all know that that's factually what's happening. We are also, I think for the most part, right, there's some outliers in here, but when we say our average age is 43 sitting in this room, we are a generation that is ill-equipped to raise the generation on smartphones, right? Like, let's just acknowledge it. I did not get an email address until I was in college. I'm like printing out the paper, right, and unperforating it and taking off the edges in high school. Like, that was like how, right, it didn't exist, right? And that was probably for most of us in this room. And so then how do we just in our core know, well, how do you raise a kid, right? How do you teach them these appropriate ways to manage their cell phone and their usage and to handle this? I say that with the silver lining of hope that the next generation did come up with this technology. This is not new to them. They made the mistakes in childhood that they may actually be better equipped to parent to and to educate to and to help drive policy around. And so we want to encourage that voice into the conversation to help us say, how do we respond to it? Because let's be honest, we don't know. That's part of the problem that we have is we go to the extremes because we don't know the right mix. And so we rely on experts, but let's also rely on those who have lived experience.
Perfect. So maybe we can get back to that original slide. And so I really just want to, I'm a dot connector. And so we've talked about what things look like on a national scale. We've talked about what Riley says things look like for our state. We've talked about what things look like much more locally, regionally. But I think what's great about this Riley initiative is Riley is a big name. They have a lot of power and potential for funding behind them. And what Riley really is looking to do is to have regional hubs, regional centers of moving things forward. And so we're excited about that big name coming behind our region, sharing resources, potentially training resources, and really that connection back to a bigger center of excellence where we can collaborate. That's truly the focus, the ultimate outcome for the study that Riley did. So they had very specific findings, and again, I'm not going to go into tons of details with all of this because you guys will have access to read it, but they found that they really want to, their kind of tagline with this study is the right care at the right time in the right place. I think we can all say that if somebody comes into services anywhere, that's good because we care for them and we give them the resources they need and we help them to heal and get better. But so often there are wait lists. So often there's not enough training. So often there's just not availability. So there's a lot of pieces we need to touch on to make the system as a whole more functional and more attainable to our children and our teens out there. So the specific things that they wanted to focus on then as a result of their findings is enabling strategies, specifically expanding the workforce. That comes as no surprise. I think our organizations have worked a lot too with IPLA, the Indiana Licensing Board. I don't think it's a secret that they've struggled for a while, but things are getting better. They've received resources, and we've already seen improvements with that. So even just helping along with the process to get people licensed up faster so they're able to serve patients faster. Advocacy on all levels. This will need conversation at the state level. And what's really wonderful too, as a collective of community mental health centers, we're part of an organization called Indiana Council, and it's organized and it's got an organized voice. And so we have advocates at a state level that go and speak about what the real needs are and where the funding should be going. And really at this point, we've got the ears of lawmakers because of the mental health crisis in our state. That's good. So then core strategies, number one is expanding early intervention and prevention resources. So a lot of that is focusing in the schools, either by school counselors, teachers, therapists, everybody that can touch the lives of children, clergy, to kind of get ahead of the issue rather than wait until it becomes a really big issue. Increasing access to outpatient services, again, that how can we multiply our efforts and really reach more children and reach them successfully. Ensuring safe intervention for kids in crisis. I'll talk a little bit more in detail about that when we talk about CCBHC and 988 and all of that good stuff. And then also ensuring the right type of distribution of inpatient services. We know that inpatient is a real need. There's never enough beds. And I think what we've seen too, as a community of caregivers, is that there's more requests for state beds. There's more requests for inpatient hospitalization. And that by itself shows us, we need to get ahead of that so it doesn't get to a point where somebody needs an inpatient bed or a state hospital bed. So this is just a little bit more detail, but in general, 85% of the Hoosier population lives in mental health shortage areas. Does that resonate for you guys? 85%. That's the majority of Hoosiers. Okay, so here they're really talking just a little bit more about some of those pieces, which you guys can all review on your own time. But I wanted to talk specifically about the 988 initiative and also what's attached to that. So our state has engaged in a collaboration effort to bring 988 here. I'm sure you've all heard about that. 988 at this point, it's the equivalent of 911, but for mental health needs. It's a huge first step, but we're still working out the kinks in that system. Who's going to answer the phone calls? What training are they going to have? What kind of reach will they have? There's lots of cross-communication between who should be calling 911 or should it be transferred to 911 or who should be calling 988 and should it be transferred to 988 between those systems. There's a fear that there might be danger involved in a situation like that if there's a response. Who should go out? Should it be law enforcement and mental health crisis response, mobile crisis response? But the key is we're doing it and we're moving in the right direction. So the starting point here when it comes to a crisis touch point for anybody in crisis is that 988 call. I don't know, Clinton, if you want to talk too about the texting options. I'm sure most people here are familiar with it, but...
Well, hypothetically, I can't talk about it, I'm slightly joking, but I do have to be careful. 988 is a state program that
right.
We do have services that we provide. Our team is the only text-to-chat partner in the state of Indiana. But I will say that, back to your earlier point, Vibrant Health is the national stakeholder with SAMHSA, and they're the ones that do all the training. So there is trying to be a consistency of the way that individuals are trained, crisis specialists are trained throughout the state. It is working. I can tell you firsthand that, again, hypothetically, we have seen incredible impact with people being able to remember that 3-digit number versus the long code that we used to have. And if I could hypothetically tell you a story of a young 13-year-old girl whose life was saved recently, it was hypothetically a wonderful thing that she was able to text 988 and she was able to get the help she deserved, and now she's in care. So again, it is a slow burn, but I'll tell you, I'm very pleased with what I'm seeing from our state leaders. I want to honor some of the feedback you've been giving me. You're frustrated with government officials, you're frustrated with a conservative government, you're frustrated with too slow. I get all that. I'm often jumping off the bridge before I even think about where I'm going, like I love to jump. But I will tell you this, that we as a state are leading. That's crazy, right? We're leading a lot of the 988 initiatives nationwide, and I can say that hypothetically today.
Well, in Clinton, we're grateful hypothetically for all that you do, so we want you to know that. I do want to just comment on what Clinton noted that he is hearing from you in the audience regarding the frustrations that you have, and also what Siquilla said about this not being a perfect process, right? But we are in a state of crisis, and the only way forward is to do something, and to do something new means we're going to do it imperfectly. And so my invitation to everyone is to embrace that. Join the party, it's crazy, right? Like, just embrace the chaos of what it is as we tweak and we move and we learn something new, and that can be frustrating and it can be exhausted. So going back again to that idea of caring for the caregiver, take care of yourself. One thing I tell my staff at work, there is never a good time to take time off. Do it anyway. There's never a good time to have a baby or get married. Please do it anyway. Please continue to live your life. Work will eat you alive. It is your job to figure out how to not let it. And it is also not our jobs as a community to say, well, that's okay, youth mental health crisis can wait, we'll put suicides on pause. It's our job to keep the gas pedal on that. It's your job to figure out where do I need to hop off the bus and then come back on later because I needed to take care of myself. That's also not an easy task to try to figure out for yourselves either, because we're all feelers, right? And we're all here, and it all feels somewhat neglectful to even step away for a moment, but you are better for it. And so I just encourage you all, just again, take good care of yourself.
I love that.
Can I jump into, one of the things we haven't talked about today is the highest group at risk among students, and that's the LGBTQ community.
Yes.
And so I can say unequivocally that group of students specifically has very focused care with the 988 strategy. And I'll also just again reference Penn State University's research of remedylive and the Get School Tour. They were able to find through their evidence-based research that the Get School Tour does a fantastic job of helping the LGBTQ community get the services they need with trusted adults like you. So again, this is working, but it's important again that we're talking about this so that the stigma can be lowered.
Fantastic. So of course the beginning was really important, having this 988 system. But as you all can imagine, all of the phone calls coming in don't necessarily get resolved at that 988 level. What happens if the person calling is really in dire need and has a crisis situation that the operator, even though they got excellent training and they're very well equipped, they just can't quite get the person to a place where they're safe? What happens next? So that is really what where CCBHC comes in, and our efforts at a state level in Indiana. So Indiana is really looking at becoming a CCBHC state. So what does that soup even mean? We traditionally have had a system of community mental health centers. CCBHC, this is probably not the way they would want me to define it, but CCBHC is almost like CMHC on steroids. It offers everything that community mental health centers have always offered, but there are key additional pieces to it. One of those pieces is mobile crisis response. Mobile crisis response is when those 988 calls cannot be resolved in a way where the operator feels, or the text provider, I don't know what they're called, when they don't feel the issue has been resolved in a safe manner, then they can dispatch mobile crisis response. It's a team of 2 that are trained mental health providers that will go out to where that caller is. Doesn't matter where you are, if you're at home or school or somewhere in the community, they will go to the person and give them additional support. What happens if that still does not resolve the issue? If that still does not resolve the issue, another big piece to CCBHC is crisis receiving and stabilization. These are hubs where the patient can be brought by the mobile response teams to a hub where they can get additional care. It's not inpatient care, so it's a step before inpatient hospitalization. And I think those pieces are so big. Our system has been talking about a need for these additional pieces forever, right? And so this is a space, a safe space, and the regulation is typically the patient can stay there for up to 23 hours. They're not hospitalized inpatient. They can get some skills from a mental health provider. They can just be in a safe space. They can get a shower. They can get food. They can get just collaboration with all kinds of providers, and they can be assessed to determine if inpatient help is needed. Most of the time we find that at that crisis receiving and stabilization hub, we can resolve what is going on for the patient. We can connect them with shelter. We can connect them with an outpatient mental health appointment. We can connect them with a primary care appointment. And they don't have to get to a place where they're hospitalized inpatient. We all know it can be so traumatic to have an inpatient hospitalization. So if we can avoid that, that also means fewer demand for those hospital beds that are never available because they're always full, right? So,
Siquilla, I would say that's one of the early findings is mobile crisis teams are helping take the pressure off emergency services like hospitals and in person. A couple of the questions that came in when I asked you about this particular strategy. These are not police officers. They're not coming with a firearm on their side as they walk up to someone's home. And that's important for you to know is that law enforcement still needs to be involved in certain cases, obviously, because there's a danger sometimes to the others as well as self. But what they're trying to do with mobile crisis is bring trained individuals with resources. And that's been very well received because most of the people caught in struggle are so isolated from those resources, so isolated from community that someone walking up their sidewalk is making an immediate difference because they no longer feel isolated in the struggle they have to take their life.
I just want to add who can actually call and request a mobile crisis intervention team, because I think we think about 988 and the person who's in crisis themselves reaching out to chat, but I think what I've heard anecdotally from our mobile team, which gets deployed from within Parkview, is really oftentimes we have family members who they have loved ones that they're concerned about, and they're calling our 24/7 helpline, which is answered by trained professionals who can help talk them through and triage the situation that's at hand. They can provide real-time guidance as to whether we feel that police need to be dispatched, if we need to head to the emergency room, if we're just moving them and expediting an appointment, or they can also deploy our mobile team out to them to assess the situation and walk that situation side by side with them. But for all of us who have loved ones who struggle with mental health and may find themselves in that point of crisis, we also know that sometimes it's really hard to acknowledge that you need that level of help. And it's a loved one, it's a sister, it's a friend, it's a parent, right, who's doing that reach for you. Now, the person hopefully will be accepting of that help, and that's part of the targeted strategy of teams of two, people with lived experience as peers, right? It's a non-threatening, it's not a police officer, as Clinton said, it's not we're here to take you to the hospital, we're here to have a hopefully very non-threatening conversation about what's going on, and that we can help you to see that you have more than just the one option in front of you that you think that you see, because we also know that when we're in a state of crisis, it's really easy to get tunnel vision, and what we know with kids particularly, right, when we talk about that youth suicide rate, suicide starts to look like that's my only option. when in reality, we may have hundreds of options that haven't actually been considered or explored or pursued. And we want to open that view to create some of that discomfort around the choice for suicide.
Where in the state has this been rolled out, and what have been the outcomes? I just wanted to know where in the state this has been rolled out and what the outcomes are so far.
Well, outcomes I can't speak to, but I can tell you that it's not nearly the 92 counties of the state of Indiana. Obviously, Marion County is pretty heavy because of the population density. There are some mobile crisis strategies going on just north of Fort Wayne that's working quite well. 4C has got some mobile crisis going on in, what counties are those, sweetie? Well, 4C is a community mental health partner. But I can tell you that to your question, there's a lot of work to do because the mobile crisis is a brand new way to approach this conversation. But the good news is that I think in our last hypothetical 988 meeting, there was new teams being added every week. So, hopefully in the next two years, we'll see all 92 counties get it, especially rural Indiana, southern Indiana, which is really a desert when it comes to resources.
And Clinton's sharing with you kind of the larger overarching plan for the state of Indiana with where the plan is to take 988 in a link to mobile crisis intervention. Where are we at today is not that final state. We are Indiana is getting ready for what's called demonstration. And so demonstration is really taking these models, putting them into practice at select, treatment centers throughout the state of Indiana so that we can collect the data to lobby to get the state of Indiana to change the way that our law currently reads to provide the funding for this to become sustainable. So there's lots of pieces in place. There are things that we are doing though. So while Parkview's mobile crisis intervention team is not tied to a 988 dispatch, it does exist. And we have a mobile team right now that can be deployed 8 to 8. Is our mobile team that they work. We have a day team, we have an evening team because those tend to be our peak hours. That team gets deployed by someone contacting our helpline. The helpline triages what's going on. They can then deploy our mobile team out. And we have deployed out into the rural communities. Obviously, our response time takes a little bit of time to get there, but we do respond out to those communities. The crisis stabilization units that Siquilla had spoken to, Parkview's also in process of developing what will that actually look like, but there are plans to open that crisis stabilization unit later in 2024. These are all things that, it's a heavy lift. We've never done it before, and so there isn't really a good blueprint to follow to say, well, give us the manual and we'll just follow it. We're discovering as we go. So do you want to share what Bowen's doing as well?
Yeah, and I know there's a question in the audience, so we'll get to you in a minute as well. But so Bowen doesn't have the mobile response team piece. We have the crisis receiving and stabilization piece, and we've already been able to help many people through that. Again, it's in that sort of pilot stage, and in most of the places where we're doing it in our state, it is in the pilot stage. The state as a whole is looking to become a CCBH state. What that means is right now we've got pockets where it's happening. But as a state, we want to kind of move from CMHC to CCBHC, meaning that every single county across the state will have these services available to folks. So that's end state. That's where we're looking to go to. So know that all those services will be coming, but it will take time for us to get there.
So I just had a comment. I'm from Benchmark Human Services, but we have a mobile crisis team. It's through our AWRC. It's very successful. They've been in action for over a year. We serve Noble, DeKalb, Steuben, and LaGrange, and they're getting ready to expand to further counties. So the collaboration that happens between all entities is so significant to make this work. I'm part of our family preservation team, so it's nice that we can have collaboration with that other team at Benchmark. But again, collaboration is key for all of this, but they have seen a great outcome from everything that they're doing with the mobile crisis. They did extended the contract, I think another 3 years with our team already. So it is expanding. We do it in other states as well. So Indiana, unfortunately, sometimes we're the last one to the table, but hopefully we do it right when we do show up. So if anybody wants information, just let me know.
And Indiana's not the last one this time around. We're doing okay. There are other states we can learn from, which is great. They've made the mistakes. They've made things better. So the ultimate goal we're shooting for here is that both mobile crisis response and crisis receiving and stabilization will be available to every Hoosier 24/7, 365.
And I just want to acknowledge, I saw a couple hands go up that I think maybe people had questions or comments that they wanted to add in as
The
well.
question box wasn't functioning, but now if you look at your screen, you can submit some questions for the team, and there are quite a few lined up, so I'm going to get them to you,
Perfect.
Jessica.
Yep. No, that's great. And we want to get to those questions. And so I think we'll kind of wrap up the information we want to share, and then we'll come back and answer questions that you guys have for us as well.
Perfect. All right. So you guys can read certainly more about CCBHC. The information is out there on the big web if you guys want to look into it. But I've kind of given you the big overview for on a state level. We talked about that, and then.
So let's talk about some exciting stuff, right? We've shared, right, the crisis. Does everyone believe we are in a state of youth mental health crisis? We have convinced you with the data, right? People are righteously angry. What are we going to do about it? And this is where I want to share with you, what are we doing about it? So this is something that while we did our community needs assessment in 2022 that identified needs for us, while we had been working plans, I will tell you, it was this fall where I just really felt like God put this heavy on my heart that we have to do more. As a community, we need to be organized. We need to have outcomes. And as I started talking to Siquilla and others from Bowen Center and Clinton and Jessica and Amanda, and there are many people that we connected with, IU, Purdue, and started talking, everyone was in agreement. Yes, we need to do something. Yes, let's pull together. So I'm excited to share with you that we have pulled together a youth mental health task force. That task force was organized in the fall of 2023. We kicked that task force off in November. We are in the early stages of mapping the work that we're going to do. This training today is actually one of the things that the task force has helped to drive of just we need to increase the knowledge of what's happening and get more people into that conversation. But I think the things that I'm really excited to share with you about the task force is we have 26 different organizations that are represented across 6 sectors. Some pretty impressive just statistics in terms of the people who are at this task force meeting. I've lived in Fort Wayne for a decade now, 10 years. This is the first time I have had all 4 school districts in the same room continuously to talk about what do we do about our kids' mental health. We have IU, we have Purdue, we have judges, we have doctors, right? We have clergy, we have leaders and superintendents, and we have people in the room. It makes me a little nervous sometimes because I'm like, you guys are really important and we need to do some good work to keep you coming, right? But we have people who are there, who are invested, who want to make commitments, who want to drive this work forward. And so while we don't have yet a full blueprint to say, hey, here's what the task force is rolling out, that's what we're working towards. And that's also going to be a call to action to the community as we develop what these sectors are working on. That there will be a call to action to say, this is what our community, our sector can do to impact mental health. And we need everybody, right, swimming in the same direction, right? Everybody getting on board so that we can have some impacts. We do want to identify metrics that we can track. Now, we have some very opinionated people who have lots of ideas, and so getting those all down to one metric or a handful of metrics that we can track and that we can share with the community is a desire that we have. So I just want to share that with you. The task force is really organized around this shared purpose and a shared vision. And this took some time. This was actually part of our initial work as a task force to say, why are we all together? And what is the purpose of us coming together in one room? Because we have to get out of these silos, right? We're not competitors, we're partners, we're on the same team here. And the shared purpose that we walked away with was just this idea that our Indiana youth are experiencing a mental health crisis, and we all feel that call to us that it is our responsibility to respond to that. For our children, for our children's friends, right, for their children, like we have to do something about that. And then our shared vision, we have adopted and joined into the larger Riley vision. This vision where youth are going to receive the right care at the right time and the right place for the needs that they have. And so the work that we're doing is really being guided by these two principles. And I think it's important, going back to those 6 sectors that are represented, so much of what we've talked about today has been youth who are in a severe mental health crisis, youth who are experiencing suicidal ideation, right, or are using substances or need that 988 response and the crisis services. But also, why are we waiting until youth mental health has reached a crisis? We all have mental health, right? You don't wait until your child has significant mental health needs that you have to take them to the emergency room. You make it to your well child visits, right? And you check off the markers as we're going with where they're going with their development. And I think the mental health system has always had this backwards. We wait until the crisis exists. We wait until we needed services yesterday. We wait until I need the highest level of care that's the least available to me, and then now I can't get it, right? But if we're really doing mental health well as a community, my hope is that Siquilla and I at Bowen and Parkview touch very few of the youth who actually need our level of care. And hopefully we can help to stand up and equip everyone who touches youth to have more tools in their toolbox, right? That those of you who are connected to the faith community, that your leaders, right, your volunteers, your congregation that works in youth ministry are better able, equipped to have the conversations around youth mental health. They know what to say, they know how to respond, and they know when to escalate up to the treatment providers. For all of us across the board, right, when all you have is a hammer, everything looks like a nail, right? When all we think about is, we'll call 988 and get an inpatient bed, right? That might not be the right answer for most of our kids. And also, if that's the answer that we need right now, what were the 100, right, markers leading up to this that we missed, right? Because this didn't happen in a vacuum. Things have been brewing, right, that we had opportunities to hopefully respond to. And that's not to point a finger and say that anyone's at fault because we've missed these things, but we've all missed them. And so how do we get better at that? How do we educate ourselves? How do we start to put some things in place where we can have these conversations earlier on, which I love about Clinton, just having those uncomfortable conversations in school with the Get Schooled tour, right? We all like to think that our youth, right, are doing pretty well, and then we kind of get the data right in our face. Well, maybe not, right? Maybe they're not doing quite as well as we would like to think that they are.
Laura, if I could just ask real quick, or add real quick, this is also not, I don't want you to hear the message that this is about shaming and blaming, that you're not doing the right thing or you're not doing enough. We recognize there are not enough resources. The point of this is to bring those resources to you. And while this task force is kind of located in Allen County, our other counties, our other providers, we see you, we hear you, we are planning to bring these resources to you as well. So don't feel like just because you're not in Allen County, you're just gonna be out of luck. We're here for you as well.
And then there have been several questions that have come in. Two of them I think I can address quickly. How can we share accurate information regarding available services to our families and individuals? Clinton, I believe you have a list of resources that you'll be sending out.
On their phones right now if they open their screen.
You already have it.
Yep.
You have it. So there is a document that you all should be getting.
Can I add real quick too?
Absolutely.
Part of the mission of the task force too is to combine a network of resources for everyone, because there are some resources out there that are actually really amazing, but what we hear oftentimes too is that people aren't aware of those. So we want to make sure that at a very quick touch point, people can access what we do have.
Yeah, that's a great point, because I did have a couple comments saying that they didn't know the benchmark crisis line was available, so awesome to share that information. Will there be continued training specific to the task force outcomes and how it is being applied in the community? The short answer, yes. Amanda and I we sit on the task force, we plan on continuing to work with Laura and everybody on the task force through 2024, probably into 2025. There's no way we're gonna be able to get through all of this or fix this within a year. I'd also mention for Great Kids specifically outside of the task force, we do trainings pertaining to youth development also often youth mental health, pretty much every month throughout the year. So if you are new to Great Kids and you're not already on subscribing to our emails, you can go to our website at greatkidsallencounty.org and request to subscribe to our emails, because we offer something like this typically once a month here in our community, and it almost always costs nothing for you to come. And as Amanda mentioned, we will feed you, right? We always joke that's Great Kids love language. We will feed you as long as you're coming here to get the information that you need to continue to be able to serve this community. And then a couple of questions that are going to be directed at the two of you. And I'm assuming these were pertaining to the 988. Someone asked, is this for suicide risk only or other crisis matters that don't include suicide? And someone else was asking about age. Who helps someone under the age of 13? Where can those youth be referred to?
It's not just for suicide. Any mental health need, any substance-related need, call 988.
And I think as far as the question as to where to connect youth under the age of 13 for services, both Bowen Center and Park Center provide those services. I will say they're a bit more specialized because the younger the child, we also want to make sure that people have specialized training to be able to effectively treat those youth. But connecting to either one of our agencies would be able to help guide those resources to you.
But I also don't think there's a limit to 988,
I'm going to read between the lines on that 13-year-old question too. The COPA law, which is the Child Online Privacy Protection Act, in regards to crisis, I mean, you probably know that there's a 33% increase in 10-year-olds and younger taking their life in America. Crisis does push COPA aside. So a child could text 988 or call 988 and still get services if they are truly in danger. So that's something that you need to be aware of. But I think, to your point, Laura, the services, the family services, there's a lot of great resources as well there to make sure that we're helping students. That we're in that sweet spot at remedylive with our warm line, which is simply 494949. And if you look at your screen here, I'll turn it on so that you can have that information, maybe take a screenshot. That's our warm line. That's what we often will do to help students and adults talk about the divorce they just went through, talk about the fight they just had with the boyfriend, talk about the pain that we have in our lives, but it's not necessarily life-threatening or imminent risk situations.
And I want to play off of that too as to how the remedylive warm line also translates into treatment for many of us. So at Parkview, we actually include the warm line as we're safety planning with clients. Because again, we want them to have that resource, right? We cannot, as a single entity, meet all of their needs. And there are times where they just need to reach out and they need to have some conversation with a soul medic at 2 o'clock on a Thursday, right? And we want them to be able to do that because they may not have the social, right, support system in place for them. And it sounds like that's the same for you at Bowen.
Same, and honestly, we have business hours of operation, right? When do people feel most desperate? It's like 3 o'clock in the morning when it's dark and scary and nobody is around. So we need to be able to provide those resources to people so they can access it no matter when.
We are in our final 15 minutes, ladies, too, and so there are a couple more questions. One of you referenced the base camp group that exists. Perhaps today, later on, Amanda and Jessica, you can get some more information. I can get you that information. And base camp is just a collection of all kinds of great providers here in our community. And of course, I wouldn't be committed to the collaboration with the Lutheran Foundation if I did not say lookupindiana.org is a great one-stop shop as well for great resources in our community as well.
There's one more quick question about the 988. Again, they're wondering if a minor were to use 988, do they need a guardian to be involved or present?
I think, Clinton, you just answered that,
Well, yeah,
right?
we'd love a guardian to be involved. That's what we're trying to say about trusted adults. But sometimes the guardian is part of the problem. Sometimes it's the parent who is overdosing on the couch. You know, this is a crisis, right? So we are just making sure that child is getting care if indeed they are in a place of danger. But yes, we would love a guardian to be involved, but no, a guardian I don't believe is required if the child has a suicide plan and they are texting or calling 988 somewhere in the state of, or somewhere in the country here in the United States.
That's
Now,
right.
where the guardian might get pulled in is on those next steps of what may
absolutely,
be
yeah.
happening next, right? And so I also don't want to lead that false illusion that, right, kids can just come and talk about suicide and we're going to take action and not include their guardians. We have to. But that initial outreach, that initial stabilization is available to them.
Sure.
There are a few little pieces that I might add about 988 that makes it not quite perfect yet at this point. So one piece about it that people should just know is that if I call from my phone, I've had the same number forever. It's a 312 area code. I used to live in Chicago a very, 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 very long time ago. That is not going to get routed to Clinton's team or anybody in Indiana. That is going to route to a response team, a 988 response team in Illinois, because that's how the system works. Another piece about this too is when somebody calls 911, 911 has the ability to then kind of like track the person if they need to for a wellness visit or something. 988 does not track back to the person. I think that was sort of a philosophy thing to be able to say, you're safe, we're here for you to talk to, but we can't track you. That's got pros and cons, right? But so those are a couple of pieces I think people should just know about.
Sure. And that's exactly the reason why they do that. Yeah. Hypothetically.
Is that the last question, Jessica? I think the last piece that we want to leave you with today, and I'm really going to hand this off to Amanda just to speak about a little bit more, is where we're leading with the task force to that first Youth Mental Health Summit. So I'll let you take it from there.
Really just going to reiterate what I touched on earlier. We are planning this Youth Mental Health Summit on Tuesday, May 21st. Again, it will be here. You should plan on a day that looks something like 9 to 4. Lunch will be provided. We are in the planning stages now of retaining all of our speakers and topics, but some of the topics that Jessica mentioned earlier and I mentioned will be burnout, vaping, addictions in general. What else did we chat about earlier?
Minority mental health.
Minority mental health. Oh, program, like initiation of a program, of a mental health program in your organization.
And I think we're hoping to, Laura, you mentioned earlier when we were talking about like cell phones and social media that we're a generation that didn't grow up with that, so it's harder for us to kind of teach that because we haven't experienced it. We've kind of had the same conversation in terms of mental health. Like, I'm 35 years old and nobody when I was growing up ever talked to me about my mental health or self-care, right? And I'm sure like there may be some of you out there that got that, and that's wonderful, but when I talk to other people, especially in this profession, they have the same experience, like, no, nobody talked to me about mental health. And so I think kind of in a similar way, like, and I tell this to my kids all the time, I'm like, I'm learning right along with you, guys. Like, nobody had these conversations with me, and I'm still trying to kind of figure out like what works for me, how to regulate my own emotions, how to process like my own feelings. So we also are looking to hopefully at the summit, and if not at the summit, to provide this sometime this year in the community as to how do we as the adults have those conversations with kids. Because we also, Amanda and I hear a decent amount from some organizations or some families that, well, we just don't talk about it because we don't want to plant the seed. And we're like, the seed is already planted. Your kids have mental health. Like, we all have mental health. And we know not talking about it obviously is not helping things, right? Like, we just saw the statistics about what our kids' mental health looks like here. So we're hoping to find someone, whether it be at this summit or to offer later in 2024, to help all of us as parents and those who are working with youth, how to have that conversation about how do we take care of our mental health and what does that look like?
One of the things that we talk about so much in Great Kids is the necessity of taking care of us as adults, or regulating and checking in with ourselves to see where we are so that we can provide adequate services to youth and families. And certainly that's not alien from the field of mental health. And yes, as Jessica mentioned so many times, I have heard, I don't know how to start this conversation. So one of my personal hopes from our work with the task force is that we start giving people the tools, specifically parents, to start having these conversations at a very young age to normalize them. Like I have people who are still intimidated to have what's, the talk, and I want this to be the other talk that they have right alongside. That this is normal, this is a part of development, that we all have mental health, and let's talk about it openly and have an ongoing dialogue, not just a talk, but let's keep chatting about this. Let this be part of our normal vernacular.
And thank you for saying that, Amanda. I think, Clinton, one of the things I love about Remedy is that you are often just encouraging people to have what you call courageous conversations, right? Yep. Those conversations that are hard to have. And to the credit of our youth that we're serving, they are much more comfortable having these conversations. It's the adults that are really uncomfortable with it, right? It makes us feel uneasy, and so we avoid it, right? We don't necessarily know what to say. We don't know how to respond. We're fearful of what response we might get. And so I love that Amanda and Jessica are saying we want to provide training. We want to equip people to be able to have those. But I also just want to invite us all into that discomfort, right? Let's enter into the discomfort of getting out of that safe space that we have and asking the questions, even though we may not like the answer that we get, because at least if we know what's happening, we can better point to resources and provide support and provide training rather than living in this false sense that we may, right, feel safer, but isn't our reality.
I'm getting a lot of feedback based on what you were talking about, Amanda. Have you had success getting parents to trainings for mental health conversations with their kids? Big NO. A couple of yeses with moms groups, like MOPS groups and things like that. But this is a major need to get mom and dad engaged.
It's huge. I always say that, unfortunately, typically the people who are at Great Kids trainings are the opposite of individuals that I wish were at Great Kids trainings to get this. So, we think of and have it all times of day, all, times of the year. We offer food. We do all the things. We go into churches, we go into schools, and give presentations on this, and it is a struggle. Parents are a struggle. There are a couple other sectors within the organization, manifold, that those can also be a struggle. So yeah, it's tough. So I guess one of the things I aim to do in the meantime, until I figure out exactly how to get all the parents in the room that I want in the room, is to make sure we're equipping the providers to keep having those conversations, to establish that relationship with the parent, to equip them and say, hey, have you thought about having this talk? Here's some tips how to get started.
And I just want to add to that as well. While we spoke to you today as treatment providers in a professional capacity who have caseloads or students or congregations, you're also just humans in the world. You have friends, you have neighbors, you have sisters and brothers, right? And I know just from my own experience of moms who know I'm a mental health therapist, and so the amount of time I am sought out for mental health guidance, right, and parenting guidance from people on my street. Can I come over? I really need to talk about, right, this thing that's happening. I don't want us to lose sight of just the natural influence and impact that we can have when we're also more comfortable in having those conversations and guiding people along those pathways as well. We may still want to steer them, right, another direction, or hey, we really want you to go to this training. But I also think the more that we are equipped to do this, our reach is broader than just our professional capacity as well.
If I can add really quickly to the task force that we're working on is really looking to include the voices of the youth. And then, of course, I'm going to give a shout out to Clinton. He's got a very big, audacious goal in including the families and the parents. So we have dreams and plans as well, just so you guys know.
We have excellent plans.
Yeah. Clinton's jumping in is what he's telling us. So Clinton's jumping in with both feet.
I will do a kudos to the foster parents. You guys are great. You do a lot of great training. You do all that you can to be on the front line, so that's an excellent group.
That is an asterisk to my conversation. My foster parents show up in droves, and I appreciate each and every one of you.
Yeah.
I just want to end, I think just, again, we started by just thanking you all for coming, but I do also want to end just with gratitude to what you all are doing every day. Gratitude that you took time out of your day to be a part of this conversation. Grateful that you are working in a very hard profession that you often don't get thanked for, right? How many people got a thank you from the kid yesterday? Probably got some other words that maybe not have been so nice, right? But maybe the thank you wasn't one of them. So I guess on behalf of our youth and our parents and our people who
Hypothetically, they're thankful.
are in
Hypothetically.
crisis, I do want to say thank you because you're doing amazing work in the community and it cannot be done without all of you.
That's great.
There's hope.
In final comments, I do want to just tell you, the survey is open now for evaluating today. We're pushed it to your phone, so go back to the original Remedy Poll tab to make sure that you can give us great feedback. Some of you have already done a lot of that in the questions, but Great Kids does want to hear your feedback today, so go back to the original tab, remedypoll.com, and go through that survey today to help us continue to make these even better. Sorry.
And I know there's a lot of you out there that want your CEUs. So please be sure to take that evaluation. The feedback really is very valuable to us, and that is also how you can indicate to us that you would like that CEU certificate. You can just check a little box letting us know that you would like that, whether a CEU certificate, attendance certificate, how you would like your name to appear on that certificate, and give us to probably, it's Thursday, so I'd say early next week to get all of those created and processed, and then you will see those via email to the email address that you registered with.
I'd say at least that. Earlier when we were talking about what kind of plans do we have, Great Kids has big plans for this year. So I'd say give us at least a week. And also know all your information, both from a remedylive perspective as well as Great Kids, is completely confidential. Yes, you are going to put your name in, and that's solely so that it appears the way that you want it to. But there's only one full-time staff member of Great Kids, and that's myself. I don't have the time to match up all of information. So it is completely confidential, and I do greatly value your feedback as I'm making decisions going forward on training opportunities. Okay?
Thank you so much,
Thank
Siquilla
you.
and Laura. And yeah, thanks
We
again for
appreciate
being here.
you.
You